If I could have the slides on, please. This is my last chance, so I hope I don't screw up. Mediastinum is clearly an area that radiography still plays an important role because it is just not accessible to direct examination. Radiologic studies are really very important in evaluating this region, in particular for mediastinal masses. So what I thought I would do is take us through this by looking, first of all, at localizing mediastinal masses, and then a little bit about differential diagnosis, and then some observations we've made with computed tomography. First question you face when you're trying to localize a mediastinal mass is in fact, is it mediastinal? I think that's important to keep in mind because they don't come labeled as, oh yeah, this is a mediastinal mass. So the first thing is, just by the shape of the lesion on a plain film, you can sometimes tell. If you look at the various types of masses, you'll realize that a lung lesion near the mediastinum is still predominantly surrounded by lung, just like when we talked about the CT, the chest wall, and pleura, and tends to have acute angles. Pleural abnormalities tend to have right angles at the chest wall or at the mediastinum, and then extrapleural masses tend to have obtuse angles. And clearly this is the type of thing we're talking about then with a mediastinal mass. And by the way, as an alternative way of noting that, if you have a lesion medially that is destroying sternum or destroying vertebral body, then you know that the mediastinum must be affected because that's in the extrapleural region there. Also, if you have a bilateral abnormality in the chest, it's likely to be mediastinal, particularly when you look at something like this. A little bit hard to appreciate where it is at first and a very intimidating case to put up, but when you start to think about it, abnormality that's sticking that far out into the right chest and that far out in the left chest is probably originating from the mediastinum and pushing out on both sides. And in fact, at the CT scan of this case, you can see this is just a huge mediastinal mass in a patient with nodular sclerosing Hodgkin disease. So the bilaterality may well be indicative of a mediastinal location. If you were to demonstrate an air bronchogram in a lesion, that would exclude a mediastinal abnormality. If it's truly an air bronchogram, clearly you're dealing with something in the lung parenchyma. But one very difficult area is sorting out a mediastinal mass from an abnormality of the cardiopericardial silhouette. That is, looking at a case like this, for example, I think you could get a fair number of people to call this a likely pericardial effusion because they tend to look this way. And other people might well say this is cardiomegaly, and in fact it's a thymic cyst that's drooping down alongside the heart. Other soft, large thymic tumors like thymolipoma may well do the same thing. So sometimes that's a difficult distinction. Now, looking at plain films to find out which part of the mediastinum something is in is very important because it really refines your differential diagnosis. There are a number of signs, not all of which we have time to go through, many of which would be easily found in Dr. Felson's chest röntgenology book. But some of the ones I would like to emphasize, first of all, using the lateral view, and I use it the same way he does, which is to draw a line down the front of the trachea and the back of the heart, and another line about a centimeter behind the anterior aspect of the vertebrae, and suddenly you've got anterior, middle, and posterior mediastinum. We'll talk about the differential using that in just a minute. But from the PA view, you can also get some idea, even when you can't see the lesion on the lateral or you don't have a lateral view available. One important sign then is the silhouette sign. Probably you're all familiar with this sign, but clearly a mass up against a contiguous structure will obliterate the interface with that structure if it really is next to it. If, on the other hand, it's not next to it, you will often still be able to see the normal outline of that structure. So, for example, an anterior mediastinal mass tends to obliterate the margin of the heart, as this one is doing, or perhaps the ascending aorta, or perhaps the superior vena cava, all anterior structures. If a middle to posterior mediastinal mass is situated in about this region, it may well silhouette the aortic knob. And finally, posterior mediastinal masses tend to obliterate the outline of either the paraspinal line or the descending aorta, depending on exactly where they're located. This lesion clearly has to be anterior because of silhouetting the heart border, and it's useful to know that ahead of time because on the lateral it's quite hard to pick out, although that will be relatively true of low anterior mediastinal masses, which are overlapping the heart, and high posterior mediastinal masses. If you can figure out where they are, that's useful because the lateral is often not helpful in that situation, secondary to all the overlying bones of the shoulder and the scapulae and so on. Another useful sign, this by the way was a pericardial cyst, is the hilum overlay sign, and this is important because in some cases you have to be able to distinguish whether in fact you're even dealing with a mediastinal mass or whether instead what you're dealing with is an enlarged pulmonary artery. And in this case what you find is that if you can see blood vessels converging medial to an apparent mediastinal mass, that's not going to be just an enlarged pulmonary artery. Instead, there is really truly a mass there. Alternatively, if all the vessels converge and end at that contour abnormality along the heart border, that's likely instead just to be an enlarged central or left pulmonary artery. And again, this was very useful in this case because on the lateral view, I think it's a little bit hard to pick out where the mass is. Of course, once you realize that it's contiguous with a heart border and that it's not the pulmonary artery, you might start to say, well, it's a little bit more opaque there. And this one turns out to be a thymoma. Now, conventional radiographic detection of mediastinal abnormality generally relies on deformity of normal contours or displacement of normal structures, or rarely on demonstration of some sort of abnormal radiographic density, fat or calcium. And because of that, I don't think anybody would be surprised if I say that large masses sometimes go undetected. I'll quantitate that for you a little bit better when we get to computed tomography. Let me talk a little bit then about differential diagnosis of mediastinal masses. I think if you have a mass that you can localize to the anterior mediastinum the way Dr. Felson's scheme is set up, you want to start out by thinking about the 4 T's, that is teratoma, thymoma, thyroid, and terrible lymphoma, just as a memory device to remember lymphoma. Of course, there are other things that can, not infrequently, affect the anterior mediastinum, including mediastinal lipomatosis, which clearly would be easily demonstrated by CT because fat is clearly picked out separate from soft tissue. Metastatic disease is an important thing to consider in any mediastinal compartment. I'll show some examples in a few minutes, but I think that's something that is not in this classic scheme that really belongs in there. Trauma may affect the anterior mediastinum in particular if trauma is anterior. And then vascular abnormalities. In particular, I think you should realize that as patients age, the aorta goes into all sorts of compartments, and so it can clearly extend anywhere from the anterior mediastinum to the posterior mediastinum. Very useful to keep vascular lesions in mind as a general rule, just because we prefer not to stick large gauge needles into them unsuspectingly. Now, looking at the differential diagnosis, this is just like using mnemonics, and that is you don't just give this list and then that's the end of your involvement in the case. You can help the referring clinician a little bit more if you start to take into account the known features of the specific patient or the specific clinical setting. So, for example, teratoma, if you can, by one means or another, demonstrate any of the usual tissues that are found in teratomas, such as fat, calcium, teeth, or water, you're certainly a long way along the road toward making that diagnosis. Teratoma typically occurs in young patients, teens, or maybe early 20s, and would be extremely uncommon in the older patient population. Teratoma has no generalized sex predilection. It's about equal males and females, although in the ones that are malignant, which is a minority of them, there is an increased predilection of malignant teratomas in males. As opposed to teratoma, we could say the converse situation would be thymoma, which tends to affect older patients, typically patients in the 50s or 60s. It would be almost unheard of to have a thymoma in a teenager, for example, so that might be useful. And then there is some controversy about the exact numbers, but no controversy about the fact that in patients who have thymoma, a significant percentage will have myasthenia gravis. The often quoted number is about 50%. Or turning it around, if you have a patient who is known to have myasthenia gravis, about 10% of them or so will have a thymoma. So this may be a very useful clinical clue in the diagnosis. Mediastinal thyroid will almost always show a demonstrable connection to the neck, if not on the plain film, certainly on the CT scan. There are other criteria that help us to diagnose mediastinal thyroid that I'll go into in a few minutes when we talk more about CT. And then lymphoma affecting the anterior mediastinum, I think you particularly want to think of nodular sclerosing Hodgkin disease, although in a relatively limited experience I've also seen a fair amount of lymphoblastic lymphoma, particularly in the anterior mediastinum. It's not as frequent, but there seems to be a predilection for that lesion to be in the anterior mediastinum. So a couple of illustrations. We have a lesion here overlapping the aortopulmonary window, although not really silhouetting anything. Pretty big lesion on the lateral. It's kind of surprising that this is the only abnormality visible on the PA, although I think people were likely to be suspicious in this case no matter what, because it is a patient with myasthenia gravis, and this is proven to represent a thymoma. Alternatively, this would be a very typical appearance of nodular sclerosing Hodgkin disease, a large multilobular anterior mediastinal mass in a young patient. Lymphoma tends to have two age peaks for when it occurs, one in the younger population, say teens, and then another peak later on in, say, the 50s or 60s. Now, if you have a middle mediastinal mass, I think this is one clear-cut exception to the way you work up most mediastinal masses, because the primary structure you want to think about with the middle mediastinum is the esophagus, and therefore I think it's useful to start the workup of a middle mediastinal mass with a barium swallow. I think that's particularly true because if the lesion is at all arising from the esophagus, very hard to make that diagnosis with CT. I've not been impressed with the ability of CT to diagnose mucosal lesions of almost any GI structure, at least in the general run of patient population, and particularly true in esophageal CA. So I think you want to start perhaps with a barium swallow to at least clarify whether it's a primary esophageal lesion or whether in fact it's something else. If it's something else, you may then want to go on to a CT scan, but you may not. Other important things to think about would include bronchogenic cyst, a variety of lymph node abnormalities, granulomatous disease, lymphoma, or metastatic disease, and again, finally, vascular lesions always deserve consideration. Here's a patient who has an abnormal contour bulge of the mediastinum medial to the right hilum, kind of pushing out, although I will point out it's sometimes very difficult to separate abnormality in the medial aspect of a hilum from abnormality in the mediastinum. On the lateral view, this clearly fits into Dr. Felson's classification of a middle mediastinal lesion, and at barium swallow, it's quite clear that what you have is a long ulcerated lesion of the esophagus that proved to be primary esophageal carcinoma. A different patient with a very similar location for a lesion, again sticking out medial to the right hilum. This time barium swallow shows a more typical extrinsic lesion, and this one, as might be expected from its location and the appearance on the barium swallow, proved to be a bronchogenic cyst. An important aspect of bronchogenic cysts, by the way, is that it's well known they may well be water attenuation at CT, but they may be uniformly higher in attenuation as well, particularly when the contents of the cyst are somewhat mucoid. So if you do a CT scan and you see attenuation numbers measuring 50 or 60, it doesn't mean you're not dealing with a bronchogenic cyst. Now, I mentioned that lymph node abnormalities are often seen in the middle mediastinum, and I think it's a good point to bring up what nodal metastases you want to consider when you see lymph nodes enlarged in the mediastinum. Obviously, the first thing to think about would be bronchogenic carcinoma, and lymphoma would also be important, but I think we can benefit from the experience of others, particularly Dr. McLeod at Mass General, who looked at a large series of patients and came up with an experience similar to our more recent experience with CT, as far as which tumors tended to give you intrathoracic nodal metastases when they arise outside the chest. And what she found is that breast was relatively frequent in this situation, gastric carcinoma, genitourinary tumors, particularly renal cell carcinoma and testicular tumors, head and neck, and melanoma. So these, I think, are important to keep in mind if you have a young patient presenting, as this one did, patient not in a good age group for bronchogenic carcinoma, had a large right paratracheal mass, also a pretty good sized left supraclavicular nodal mass. This turned out to be metastatic embryonal cell carcinoma. Posterior mediastinal masses are pretty easy because most of them are neurogenic tumors. I mean, far and away the most common, so it's probably the shortest differential list of any of these. There aren't a lot of other options. Once in a while, although in my experience relatively rarely, you'll see extramedullary hematopoiesis, and usually that will occur in a setting of somebody with a known congenital anemia that would lead you to suspect that. That's usually bilateral, relatively symmetric, and usually in the lower mediastinum. Disc space infection may produce a posterior mediastinal mass. Once in a while, lymphoma will be posterior, but that would be uncommon. Vascular lesions, again, I haven't seen many metastatic lesions. I think I've only seen one in the 6 years I've been in Michigan, so that wouldn't be high up on my list. Now here's a lesion near the apex of the left hemithorax. A little bit hard from this to know exactly where it's arising, but just from the fact that it's so sharply defined above the clavicle, it's quite clear that it must be posterior, because if you check it out on yourself, there's no anterior lung above the clavicle. So this has to be posterior. Now, whether it's pleural, parenchymal, or mediastinal really couldn't be stated with certainty from this radiograph, but as it turns out, it is posterior mediastinal, and therefore it's not surprising that this one's a schwannoma. Sort of interesting, though, in a way, it's not what you'd expect. If you have a patient who's known to have neurofibromatosis and you find a posterior mediastinal mass, there's a pretty good chance that you're not dealing with a neurogenic tumor. Very hard to come up with exact numbers about this, and I'd be real interested to compare experience with other people because I've been looking and looking and never really seen anything about this. But I would guess it's about half and half as to whether posterior mediastinal masses in neurofibromatosis patients are neurogenic tumors or lateral meningoceles. I think it's about half and half. And certainly my experience has borne that out with some of the cases I've seen. There's a large mass here seen a little bit through the heart, better seen perhaps on the lateral view, clearly posterior in location. And at CT, it's very clear that these are water attenuation. It turns out they're bilateral lateral meningoceles in this patient with neurofibromatosis. CT would be a nice, easy, non-invasive way to make that diagnosis. Alternatively, here's another patient who actually was not originally known to have neurofibromatosis, but presented for resection of an acoustic neuroma, and head CT showed bilateral acoustics, which is a pretty good clinical clue to the presence of neurofibromatosis. Chest radiograph showed this lesion at the left apex and another lesion, actually I think it's this one right here, posteriorly in the mid to lower dorsal spine, and these were both resected and both turned out to be neurogenic tumors. Well, computed tomography is clearly something we're doing a lot of these days in patients with suspected mediastinal masses. I think I have no qualms about doing it in almost every case of a mediastinal mass, with the one exception that I mentioned before, that it might be worthwhile to start with a barium swallow when you've got a middle mediastinal mass. But CT is usually the first study you get after you've proven that somebody has some sort of plain radiographic abnormality that might be a mediastinal mass. And in fact, in some situations, it's clearly indicated even with a normal chest radiograph. The classic example of that is, again, a patient who's got myasthenia gravis, where thymoma is suspected. And there have been several series that look at that situation, but in one, 7 of 16 patients with thymoma had either a normal or an equivocal plain chest radiograph, and 5 of those 7 had CT evidence of thymomas that were missed by the plain chest radiograph or only equivocally seen. So it's quite clear that in selected circumstances it's still worthwhile to go ahead with CT for a mediastinal mass, even if the plain radiograph is normal. And that's because there are a number of advantages that CT has in looking at mediastinal masses, the first of which is detection. I think as an example of that, I'll show you this lesion, although this one was seen on a lateral view because it was calcified. It's a thymoma, and if you took a non-calcified thymoma like that and stuck it on a PA and lateral radiograph, I think you would have no hope of seeing it. And yet, even if this were not calcified at CT, I think it would quite clearly be seen. And again, I'll give you some idea of what I think is the relative accuracy of these studies in just a moment. Confirmation of location and extent can be very useful because some mediastinal masses are hard to localize even with a good PA and lateral radiograph. So if you can clearly localize where the abnormality is and point it in the direction of the mediastinum, you may well come up with a better idea of the differential diagnosis. Now, a very important role of CT is in the identification of other than soft tissue attenuation in a mediastinal mass. And in particular, we like to look for fat, calcium, and water. Here's an example of an anterior mediastinal mass that predominantly looks to be water attenuation, but there are also some foci within it that are lower in attenuation, look like fat, and this was suggested to be a teratoma, and in fact, that's what it proved to be. Here's a middle mediastinal mass that is water in attenuation, so that this would be very good for bronchogenic cyst, which it proved to be. Although, again, let me remind you, it can be higher in attenuation and still be a bronchogenic cyst. Finally, looking at calcium in a lesion in a posterior mediastinal mass, this almost always indicates not only a neurogenic tumor, but a neurogenic tumor that has some elements of neuroblastoma in it, and this one's a ganglioneuroblastoma. So the ability to identify these abnormal attenuations may help you to come up with a more specific diagnosis. Now, again, I've mentioned before, it's sometimes hard to separate a mediastinal mass from the heart or the pericardium. CT may be somewhat useful in that regard. This is the same patient I showed you earlier with what looked like perhaps a pericardial effusion or cardiomegaly, but at CT it's quite clear that next to the heart there is a separate lesion. Wouldn't be able to tell if it was a pericardial or a thymic cyst from this, but it does look like a cyst, and as I mentioned earlier, it proved to be a thymic cyst drooping down along the side of the heart. Enhancement characteristics may also be useful in your differential diagnosis, certainly something you can't tell from this plain film, although there was a suggestion that this was abnormal because in a young patient, I think she was in her 20s, looked like too many contours and too much prominence in the region of the aortic arch. And the reason is that there was a mass sitting right alongside the aortic arch. From this bolus CT scan with good enhancement of the aortic arch and the SVC, you can see that the mass is also enhancing significantly when you compare it to the adjacent chest wall musculature. And at the University of Michigan, unlike most other places, this is going to turn out to be a pheochromocytoma in the chest because we have I-131 MIBG. This is an I-131 meta-iodobenzyl-guanidine scan, which localizes in pheochromocytomas. I think in most other places an enhancing mediastinal mass is likely to be a thyroid abnormality, say an intrathoracic goiter, but at U of M they're almost always intrathoracic pheochromocytomas. There are other mediastinal masses that enhance. I think thyroid is number one. A variety of so-called paragangliomas belong on the list because there are common cells of origin not just for pheochromocytomas outside the adrenals, but also aortic body tumors, carotid body tumors, And we've found that in several different cases, different cell types, these all have some tendency to show enhancement. Castleman disease is an idiopathic enlargement of lymph nodes that tends to be relatively vascular, and I'll show you an illustration in a moment of how that enhances. Carcinoid tumors are known to be pretty vascular and may show enhancement. There are certainly other things. I've just recently seen a case of what looked like a neurogenic tumor, but it showed some foci of enhancement. And if I had taken that tumor and put it anywhere else in the body, I probably would have called it a hemangioma, and in fact that's what it turned out to be, a posterior mediastinal hemangioma. So I don't think we've covered everything, but I think the common ones are the ones we've listed, and even Castleman's is not all that common. Here's a middle mediastinal mass. Bolus intravenous contrast clearly shows a lot of enhancement, and this was proven to represent Castleman disease. Well, with all of that and with these various advantages, I thought it would be interesting to look at, first of all, what the relative accuracy of conventional radiographs and CT would be in detecting mediastinal masses. And then second of all, does CT improve the ability to arrive at a specific diagnosis? This was sparked in part by this case. This was actually after I'd been in Michigan about a year, and I looked at this one day and I thought, if I had ever seen one of these before, I would for sure know what it was. But since I hadn't, I didn't know what it was with all these big lumps. Now, I thought that this was likeliest to represent lymphoma because of what I figured were multiple enlarged lymph nodes. I showed this to my colleague, Gary Glazer, and Gary thought it was most likely metastatic disease. And any of you who know Gary will realize there's not a good percentage in disagreeing with him. And it turned out he was right. This is metastatic disease, although in a moment I will show you something that I think vindicates me a little bit. In any event, sparked by that case, we looked at a few years' worth of experience and really limited our analysis to proven mediastinal masses. We ended up accumulating 133 of them. And we looked at a variety of CT features that might or might not help to come up to a specific diagnosis, such as whether the mass was discrete and focal or whether, in fact, there were multiple masses, more of them were discrete, localized by mediastinal compartment, looked for the various associated findings that might be useful, such as enhancement, fat, calcium, water, and also looked to see if on the CT scan there were other abnormalities in the chest or upper abdomen that might help us. And again, what you ultimately come out with when you do something like this will depend a lot on the specific patient mixture in your own hospital, but we found out that most of the cases turned out to be lymphoma predominantly or metastatic lung cancer, although there were also other metastatic diseases involving the mediastinum. Fair amount of esophageal carcinoma because there's a lot of interest in our institution in different approaches to surgery for esophageal carcinoma. Some mediastinal thyroids, sarcoid, and then there were a few other things as well. And first of all, addressing the issue of relative accuracy, we found out that chest radiographs detected only 69% of these masses. This was especially a problem in the middle mediastinum. I think that's not a surprise when you think about how many soft tissue structures there are and how little lung contacts the middle mediastinum. In fact, the largest mass we missed was in the middle mediastinum, and it measured 6 by 5 by 7 centimeters. Made us feel pretty bad. Multiple masses were more frequently detected than discrete masses, although we didn't always appreciate with plain radiographs that they were in fact. Sometimes we saw one big bulge, and yet at CT it was clear that there were 2 or 3 or 4 masses there, but about 80% of the ones that were multiple were detected. Now, as far as then looking at it to see how did CT improve the specific diagnosis, well, first of all, the specific attenuation features we talked about, calcification, ossification, contrast enhancement, water attenuation, and so on, turned out to be relatively uncommon in this series of patients. Of course, that's no surprise when you realize a lot of them are lymphoma and metastatic cancer. And we had none in this particular group over a couple of years with fat in them, so that was a little bit disappointing. There were associated abnormalities in the chest or upper abdomen in many, but as far as whether they really helped or not, the answer was generally not. I would say one thing for sure, that CT could generally not distinguish metastatic disease from lymphoma from sarcoid, and in fact could not distinguish metastatic lung cancer from other metastatic disease, could not often distinguish Hodgkin disease from non-Hodgkin lymphoma. There were a few guidelines we were able to come up with. One is that lymphoma very rarely presented as a single middle mediastinal mass. So since that was the most common thing on the list, if that was your morphology, I think you could pretty well eliminate lymphoma. And also lymphoma was a lot more likely than metastatic disease if it turned out that there was concurrent axillary adenopathy. I'll go back to the case I showed you before, proven to represent metastatic anaplastic carcinoma, probably lung primary, and then show you another case I subsequently saw, which to me bore a superficial resemblance to it, again with multiple lumps, but this one associated with axillary adenopathy, and this one did turn out to be lymphoma. So I guess I shouldn't feel I was completely wrong in that when I saw those multiple lumps, I thought they might be lymph nodes. If you see a solitary pulmonary mass, but not multiple nodules, focal lesions in the liver or bone lesions, this very strongly favored metastatic disease. Any of those could occur with lymphoma, but they did not often occur with lymphoma, so it was much more likely to be metastatic. If you could demonstrate contrast enhancement, which again was relatively rare, seen in only 10 cases, this would virtually exclude lymphoma and metastatic disease, and since those were the two most common overall mediastinal masses, that's a somewhat useful finding. But it turned out that in the group as a whole, I think we were only able to make relatively specific diagnoses in 16 out of 133. So I would say that we wouldn't want to overdo our enthusiasm about how well CT is allowing us to make extra diagnoses. It certainly gives us much better information than conventional radiographs, clearly especially in the cases where the conventional radiographs are normal. But even so, it does not frequently lead to these specific diagnoses that we were hoping we would make. So I think that's an important message to take away from this. As far as magnetic resonance imaging, just to conclude, what is the current status of it? Well, I think the studies that have been done have generally suggested that magnetic resonance is comparable to CT in lesion detection and at least so far in lesion characterization. There are clear-cut MR advantages, the ability to do multiplanar imaging, the lack of ionizing radiation, and the lack of a need for IV contrast, and maybe in the future tissue characterization. But at the current time, I don't think magnetic resonance meets the needs that we have for mediastinal masses because of limited availability, the cost of an exam, and particularly examination time. We need a workhorse to look at mediastinal masses as well as other lesions, and right now I think that's CT. But I do think that in problem cases, once in a while, MR may in fact help out, particularly when you're not able to give intravenous contrast, for example, patient with contrast allergy. It may well be useful to get magnetic resonance scanning. Well, with the completion of this talk, I'm now a free agent, and I'd like to reverse a very ominous trend of recent years where free agents from Michigan end up coming to California. So I'm going to be a free agent who goes from California back to Michigan. Thank you very much.